All right, so I'm Jeff Boss, or Dr. Boss, Owen's dad. I'm a radiologist, so I'll talk to you about radiology today. Okay, so radiologists are doctors. You have to go to medical school to be a radiologist. The main thing that we do is review a variety of imaging studies like X-rays, CTs. We say what we see, and we try to sum it up in an impression, and that gives the ordering provider an idea of what they want to do going forward. We do perform some procedures. Some people perform only procedures. We'll talk about that later as well. And you may have to go to some meetings if you work in a hospital. Some radiologists choose to work only at home, which is kind of nice. Here's an example of a typical workstation. This is mine. I just pulled this off of the web. So we typically have about 3 monitors. The center one is what we use to view the images. One at the side will show a list of cases to look at. If I open a case, it'll show that particular patient's prior exams. I want to compare to them. The other monitor will have the dictation software, the software with voice recognition that I use to create reports. And it's a little picture of a microphone that I would use to make the reports and tab over and insert templates and stuff. Here's an example of a template report. So this one's for cervical spine CT. So when I open a cervical spine CT, I can hit a button on the microphone and it'll pull up in this. And I can tab over to history and add what the history is, tab over to comparisons, what exams I compare to. And under findings, this is a list of like what I see. It's kind of a reminder for me, like a checklist of what to look through so I don't forget something. And if everything is normal, I can just leave it like that. Like the one there says pubervertebral soft tissues within normal limits. It's kind of easy if it's a negative exam. Everything is ready to go. And that's about it for creating reports. So a typical day, it's going to depend on like where you're working, who you're working with. So typically for me, I might spend most of my days I spend just reading exams, one after another all day long. But today one person wasn't there, so I did have to do I think 3 or 4 procedures today. Some people will do only procedures. It's kind of what kind of job you want to have, I guess. As far as how do you become a radiologist, you have to go to medical school, so that's 4 years. After that, you do a 1-year internship. Most people choose internal medicine. Some will do surgery. After that, you do radiology residency for 4 years. And after that, you can do a fellowship. Most people nowadays choose to do a fellowship. That's when you subspecialize, like you want to do a particular type of radiology. So what I did was I went to University of Louisville for med school. That's 4 years. And then I went to Mizzou for 5 years for internship and residency. After that, I chose to do a fellowship in MSK, musculoskeletal radiology at IU. Okay, so like I said, you can pick different fellowships, what kind of a radiologist you want to be. So I kind of operate now as just a general radiologist. I kind of do a little bit of everything. I did a fellowship for musculoskeletal. So these are people who look at mainly MRIs of joints like shoulders, elbows, muscles, bones, whatever. Neuroradiologists spend the time looking at brains and spines. They do some neck work and some skull-based work too. Body radiologists mainly look at the abdomen. Women's imaging, that's mammograms, ultrasounds, MRIs, and they do some breast biopsies also. Chest is obviously chest, peds is peds, nukes I'll explain later, and interventional radiology is a totally different category. These are people who spend almost all their time just doing high-end procedures. I'll talk about that later as well. So I was planning on going like modality by modality type of exams that we read. First would be X-rays or radiographs or plain films. I'm sure you've all seen these before. They're made of X-rays, which is a type of electromagnetic radiation. There's several types like visible light, ultraviolet. These are very high energy, so they're going to pass through most things pretty easily, like your skin, soft tissue, fat is going to fly right through those, but they're going to be stopped by bone. So here's an example of an X-ray machine. So the machine is going to fire an array of X-rays through that patient's foot, and there's a detector on the other side of the foot. So X-rays are going to be blocked by things like bone. And if it's blocked, it's going to look white on the X-ray. And if it's not blocked, it's going to look black. So here's an example of that. So the more dense something is, kind of like metal, the whiter it's going to look. So in the X-ray right there is a little metal ring. It looks very white. Next down, you have bone. So part of the bone is going to be very white, like the periphery of it, the cortex. Centrally, it's still white, but not quite as white. Soft tissue, like muscle, going to get pretty gray. Fat, it's going to be very gray, and the air is just black. Here's an example of a lateral view of the cervical spine, so we can look at the different densities. So outside the patient, obviously, it's just air. It's black. In the airway, it's black. Soft tissues can be kind of gray. And bones are going to be varying shades of white depending on how dense it is. So a normal chest X-ray. So obviously the lungs are going to be pretty black because there's lots of air in there. Not quite as black as the air outside of the patient because there is some lung tissue in there. Heart's fairly whitish, and the bones are even whiter. It's an abdominal X-ray. So you see some black areas. That's going to be gas, air. It's air in bowel. That's going to be your stomach over here. A little bit of scoliosis. It's a hip X-ray. So you see something very, very wide over there on the right side. It was the patient's right, and it was our left. So that's metal. That's an artificial hip. So I thought I'd show you some typical exams that I might see another day. I showed you already a normal cervical spine. So here's admiral one. So here we have vertebral bodies, and you have disc spaces in between them, which is soft tissue. So it's going to be very kind of darker. It's not very white. This is a normal amount of space. If you look down lower, that space is nearly gone. So this is basically arthritis. And I thought we could maybe have people guess where abnormalities are, maybe. This is a chest X-ray. I showed you a normal one already. So that's abnormal. Does anyone have any idea where the problem might be? Yeah. That's a good thought. Oh, that's actually okay. That's okay. Excellent. Yeah, that's right. Yeah, so there's opacity on the right side. So the left. So like I said before, I'm saying right, but that's our left. That's the patient's right side. If you look at the left lung, it's pretty uniformly black, except for these little lines or blood vessels. And over here, you see a big white area. So there's something in that lung that's blocking some of the X-rays, right? So in this case, it's a pneumonia. You can't know for sure that that's a pneumonia. There could be a mass like centrally obstructing an airway, but that's a pneumonia. And unfortunately, the findings are not always that obvious. So here's the same thing, another pneumonia. It's pretty subtle. Probably doesn't project very well on the monitor here, but yeah, you barely see it at all. There's a little subtle opacity down there. That's another example of pneumonia. That one's really hard to see on that screen. Any idea what the problem is here, what the abnormality is, what the findings are? Okay. Anyone?
So I've never seen it before.
Okay.
But the disease describes the shape of these things. If it is what I think it is. Is that tuberculosis?
No.
I was thinking tuberculosis, but I may be.
I mean, you can get little nodules with TB. Usually they're smaller, or you can get like big cavitary lesions of lung aphyses. But there's numerous little masses. You see them everywhere, little dots all over the place. Yeah, so all these little dots everywhere. All right, it's metastatic disease, a cancer that spread from somewhere throughout the lungs. Yeah. Any idea on this one, where the problem is? Just look for symmetry, like compare the right lung to the left. Anyone? No? Anyone? No? So the right lung it's kind of dark. It's not as black as over here, right? There's some lung tissue in there. If you look at the other side, that's black, right? Hmm? A wound? A wound can cause this for sure. Yeah, usually trauma causes this. Excellent. Yeah. Pneumothorax. So you have a potential space between your lungs and your chest cavity. It's like a vacuum in there. So like when you inhale and your chest expands, it kind of pulls your lung to expand like a balloon. But if air gets into that little potential space, then you can drop your lung, right? So yeah, that's it. It's collapsed all the way down to what you just, yeah, that entire lung collapsed down that small. Yeah, so that person's getting a chest tube for sure. Yeah. Okay, maybe a little bit harder. If you maybe don't think about medicine, like, so the abnormality, you guys can probably see the abnormality. Any idea? Anything asymmetric? Yeah, exactly. Right. So that's pretty big asymmetry there, right? So you have this thing sitting here. Any idea what that might be based on? Like things are black or air, white or more dense. It's hard. So this is pretty black, right? A little bit blacker than this. Then you have like a straight line right here and something below it more dense. So this is air and that's fluid. So that's air fluid level in the lung. So something, it could be like an abscess, focal infection, like pus in there. It could be a necrotic tumor. It started to like kind of die and degrade. What else? Okay, this is an abdomen with an abnormality on it. Anything asymmetric? Anybody see anything? You can't cheat. Okay, so there's an asymmetry over here. So it's pretty dense. It's pretty white, right? Yeah, it's very white, right? So I mean, it's every bit as dense as the bone, right? So it's kind of like a rock or maybe a stone. Oh, yeah, right. Kidney stone. That's right. Yeah. So as long as it stays there, like in the kidney, it's not a problem. But once it goes for a little swim down the ureter, then it gets stuck and causes pain. And actually, you can't know for sure that's a kidney stone on this exam, because it could be like on the skin. It could be anywhere from here to here, but that's a kidney stone. Okay. Hand X-ray. Anyone see an abnormality? Excellent. That's exactly right. Fifth metacarpal. So what it's talking about is right there. There's a little step off. You can tell this broken. It's kind of bent forward, angulated. So this one has a name. A lot of fractures have names. This one is called a boxer's fracture. Probably, I don't know this one. I saw like 2 or 3 of these already this week, but they were all old and healed. But yeah, like people punch and they land on the outside of their fist, that bone likes to break. So don't hit with your pinky finger. Any idea what happened here? Yeah, yeah. So, so little white dots is obviously metal, and in the foot, it's a shotgun injury with fractures. I'm sure that bone's just destroyed. Okay, another type of X-ray. So up until now, all the X-rays have been kind of like plain images, still images. Fluoroscopy is like X-ray video, kind of. We do these for different procedures, like GI procedures, like looking at the esophagus, swallowing. Some people might aspirate their food. It should go down like your esophagus to your stomach. You can aspirate, it goes into your lungs. That's bad. So we look for that. Evaluate the esophagus, the stomach. Sometimes we'll do an enema. GU, genital urinary, we'll look at the bladder. And we do some procedures too. I'll talk about those in a second as well. Okay, I don't know how to start that. It's an example of the esophagram. Okay, there we go. So I did one of these today. So I just have the patient drink barium, and I video, and I make sure the swallowing is normal. There's no masses, obstructions, no big hiatal hernias. We give them a pill also to make sure that goes all the way down, doesn't get stuck somewhere. And this is a modified barium swallow, making sure somebody does not aspirate. So I don't know if you can tell, but the contrast is being swallowed is going back down the esophagus and not in the airway. And some procedures we do are arthrograms, so joint injections. Mainly it's shoulder, hip, knee. Sometimes we'll do some other ones, some smaller ones. We'll do some pain injections also. I don't need to go through that. That's just how I do it. So this is an image of shoulder arthrogram. So I start by just putting something metal, like a paper clip, over the patient. I'll mark the skin where I want to go in through. I'll numb them, and I'll put a needle all the way down into the joint, and I'll touch the bone. Once I get it down on the bone, I inject the contrast and pull the needle out. So here's an example of a different one after contrast was injected. So the reason for doing this is some structures are more easily evaluated if they're covered by contrast. It's like one in particular, like the labrum in the shoulder, that can tear in athletes. It's kind of a supporting structure of the shoulder. And if you're young, they'll go in to repair that. If you're older, they'll probably just let it be. But it's really hard to pick up if you don't have contrast in the joint. It's an MRI, a post-arthrogram MRI. So all the bright stuff here in the joint space is that contrast that was injected. And here you can see a little tear of the labrum, the contrast going into the tear. Without the contrast, you wouldn't see that. Yeah, sure. So this is the superior labrum right here, the black thing right there, kind of triangular this way. And there's a little white line kind of creeping up into it. See there? Yeah, so that's the tear of the labrum. Having the contrast in there lets you be able to see it go into the tear. And without the contrast, it'd probably be invisible. We also do some other procedures with fluoride. I didn't talk about those, like lumbar punctures, myelograms. The myelogram is just lumbar puncture where you put contrast into the spinal canal, and they go for CT. That's mainly for people who can't have an MRI for some reason, but I didn't include that. Okay, next modality is CT, or a CAT scan. This is basically a bunch of X-rays. So this is a CT scanner. So the patient will go into there, and CT, so the X-ray machine will spin around the patient really fast and take tons of X-rays, dozens every second. And the computer uses that information to construct a 3D image in multiple different planes. Here's an example of what it looks like with the cover off. So that's what's going on when you're in there. Okay, so we talked about the different densities of X-ray, and for CT, it's basically the same. So air, it's going to be black, and the more dense something is, the whiter it's going to get. So bone is going to be very white. This is oral contrast. We'll talk about that in a minute. But one cool thing about CT is I can actually draw an arrow, press a button on my keyboard and draw an arrow around structures, and the computer will tell me how dense it is. It'll give me a number. So like if I'm looking at a renal mass, and I want to know if it enhances after every contrast, if it has a lot of blood supply, instead of me just looking at it and being like, okay, that looks like it's enhancing, I can have the computer tell me exactly how much it's enhancing. So water, 0, the more dense something is, the higher the number. And there's different planes that images can be displayed in, mainly 3, axials, like the green square, kind of traversing him this way. Coronal, it's like looking straight at the person, and sagittal is like a side view. So here are the different planes. So it's axial, coronal, and sagittal. But the CT tech, if I call them, they can make any plane I want. So if I want to come in this way, they can do whatever I want. Oh, and also 3D. These are kind of cool to look at, but I really don't find them very useful. But this is a 3D of a pelvis. A couple of fractures, superior pubic ramus, inferior sacrum is fractured over there. And they can spin too. This is obviously an ankle. Mm-hmm. Yeah. 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 They do these routinely for a lot of bone exams. They do it for PE chest, which I'll show in a little bit, looking for blood clots in the chest. But they can make them for other stuff too. But yeah, there's a tibial fracture there. Here's one of the abdomen showing the abdominal aorta, arteries coming off, kidneys. They need to look at. Maybe a surgeon might like to look at that, but it really doesn't help me in reading cases very much. Okay, so another thing that we have for CT that's different than X-rays, we have different windows. So this is the same image, and I can press a button on my keyboard and show different windows. So here's a soft tissue window. So it's really good for evaluating soft tissues. You can tell a pretty obvious difference between the back muscles and the fat over here and the heart. And evaluation of the lung is pretty terrible. It's just black, just like the air. So this is good for soft tissue. This is a bone window. It's really good for evaluating bones. Lungs are terrible. Here's a lung window. So lungs are really good, and everything else is terrible. And it's a good picture of a bone window at the base of the skull. You can see the details, like super good, but everything else is awful. You can't see the brain at all. Okay, with CT, you can inject IV contrast. This can help evaluate different things, like finding masses. So if you can imagine you had a mass in your liver, and if it's the same density as liver, you may not see it at all, you know? But if you have contrast, it'll enhance differently. You can stand out better. You can evaluate arteries when they're filled with contrast, looking for little areas of narrowing. So here's an abdominal CT, and clearly there's a mass in the liver here. But at this point, you can't know what that is. If it's benign, malignant, if it's an abscess, infection, you can't really know, so we give contrast. And now it stands out a lot better. And you can look at how it enhances over time. So this is an arterial phase CT. So they injected the contrast, and when it was in the arteries, they scanned. They waited a little bit longer for the contrast to get into the veins, and they scanned again. And even later, it's over here. So just from learning in residency and looking at this enhancement pattern, I know that that's a benign hemangioma and it doesn't need to be biopsied. You can also evaluate arteries like I was saying. So here's the abdominal aorta, celiac artery, SMA coming off. So if there was no contrast, that would be gray, just like the bowel over here. And if there was non-calcified plaque in there, I would never see it. So we give contrast to find plaques, to find areas of stenoses, narrowing in the artery. Oral contrast. So on the left, we have the CT with no oral contrast. And on the right, we have oral contrast. So this usually isn't really necessary to do, but sometimes it can be helpful. So here's a clump of bowel over here. So if there was a mass in that area, the same density, it could be missed, could be mistaken for being bowel. But once you get rural contrast, there's no question what's the best barrel over here, right? It's super bright. Okay, so we're going to do some cases now. This is a normal non-contrast head CT, kind of going through like this. Again, there's lots of symmetry, so you want to see symmetry. And here's an abnormal. Anyone have a guess as to what's going on? Anyone? Oh, yeah? Excellent. Right, so over here? Over there? Yeah, that's right. Yep, looks good. Okay, so the white circle is obviously very dense, so it's going to be your skull. And then you have your brain here. So let me go back to the prior. So your midline is right at midline where it should be on the normal one. And over here, midline's way over here, right? So this, whatever this is pushing the brain over to the side. And it's pretty dense. That's acute blood. So that's called a subdural hematoma. And the person's probably going to have to go to surgery to get that evacuated out there. So CT with IV contrast. You guys probably see the abnormality, asymmetry somewhere. Yep, right. So there's a mass, left frontal region. That's a benign mass, it's meningioma. Yeah.
How many CTs are you, the ones that are transaxial, are you looking up from the bottom at all of them, or are you looking down from the top at some of them?
I think the best way to imagine is looking up. Like you imagine that you're looking up. I didn't figure that out until like well into my training, so I imagine looking down. But I guess it doesn't really matter. But it makes the most sense to imagine looking up.
Well, if you go back to that last one, the only way for that mass to be on the patient's left is if they're looking.
Up, correct. Yeah,
And
correct.
is that consistent, or does your view change when it's transaxial?
It's always this way. Yeah.
It's always that way?
Mhm.
Okay,
Yeah.
so that's helpful.
Yeah, yeah.
Because I never know, like when I see, because we've got like access to some like samples, and I don't know like if this is like, are we looking down, or are we looking up?
Yeah, it's better to look up.
Okay.
That makes a lot more sense. Yeah. Yeah, yeah. Okay, this is a axial CT of the chest. Little diagram up here shows you like where it is. So we're above the heart, kind of cutting across this way, going through the major arteries that leave the heart and go to the heart. So it's a quick little anatomy lesson here. So here, the biggest artery that leaves the heart is your aorta. So it's going to come up and then arch back down. So here we're coming up, and it's arching above this picture, and then going back down over here. And that feeds your entire body. And this is your main pulmonary artery, which supplies your lungs. Comes this way and splits into right and left. And here's the same thing on a different patient with an abnormality. You want to guess what the problem is? So it's very white. It's uniformly white because it's uniform contrast filling the arteries. Or it should be, right? The aorta is, but this one is not, right? There's something else in there, in the artery. Anyone have a guess? No? So it's a pulmonary embolism with a blood clot. Yeah, sure. So all of this dark right here, all of that's all blood clot. So filling this artery. So this artery should look like this one, right? All of this should be uniformly white, filled with contrast. So there's no contrast where this dark stuff is. That's just blood clot. So like if you go on a long trip, you're driving or flying or whatever, you should get up and move around so you don't get clots in your leg because those can break loose. And this is where they go, into your pulmonary artery. So if it's a small one, if it's peripheral, like the arteries are just like trees, right? They branch and branch and branch. So if it's a little small one way on the periphery, it's probably not a big deal. If it blocks blood flow to a tiny portion of the lung, maybe not a big deal. Now, if you have a big one sitting here blocking your entire lung, that's a huge deal, right? It's going to be life-threatening. So if they're kind of smaller, they'll give something IV just to break down the clots. But if it's big like that last one, they'll probably call interventional radiology, and they'll run a catheter all the way up to this artery, and they'll inject a medication like right up against the clot to break it down. Okay, this is pretty hard, but normal lungs over here, and this is abnormal. It doesn't show up very well on the monitor here, but there are little black cystic areas scattered throughout the lung, like here, and here it's getting really terrible. This is severe. Last was moderate. I call this severe. You have a huge area basically non-functioning lung. Over here, kind of everywhere over there.
What is the angle from it? Where are we looking?
Oh, it's a chest. So we're like, it's like right. Well, this one is through the heart level, so like right here, and this one's a little bit higher up, so it's like right here.
So you're looking like up.
Yeah, yeah, yeah. It's kind of like cutting somebody this way, you know. Does that make sense?
But the black is the lung, right?
Correct.
So why does it take up the whole entire space?
The entire chest?
Yeah.
That's a good question, actually. Yeah. So that's part of the answer is tied up in there. Why are the lungs so big? Is that what you're asking?
I just didn't think they're that big. I don't know.
Well, this person's pretty malnourished, like super thin, like almost no subcu fat. So that's going to be part of it. But part of it is the lungs are hyperinflated. So these areas of like non-functioning lung are like expanded, right? So this person's going to have like a barrel chest. They're like this all the time. They're going to have trouble exhaling. So how do they get like that? Or you might know what the disease is? Hmm? Yeah. Anyone want to throw out a guess? Okay. Emphysema. So smoking. So you don't want to smoke. It's a real thing. I see this all day, every day. That person's going to have a hard time exhaling. Okay, here's somebody, another person with emphysema. Doesn't show up quite as well here. And there's asymmetry, an abnormality. I'm sure you guys can probably see it pretty well, right? Here. Okay, so what might that be? Here's some smokes. It's in the lung. Yeah. You can't know for sure that that's lung cancer on this exam. They'll probably have to get a biopsy or a PET CT or something, but that's a lung cancer, yeah. Okay, I'll just probably explain this one. So we've seen this level of the chest before. We know that's the ascending aorta, it's the descending aorta, but clearly it looks strange, right? So they injected contrast, but part of it's like really bright, and part of it's not quite as bright. So I'll just tell you, this is called an aortic dissection. This is pretty scary to see, because if you have it right here in the ascending part, it can be life-threatening. So basically what's going on here is a little tear in the inner lining of that artery. And then as the blood's flowing through the artery, it can push into that tear and kind of dissect out that inner lining, kind of make a new cavity, a new tract for the blood to flow. So basically this blood here, this contrast or blood is flowing into the wall of the artery. And here it's in the normal lumen. So it's pretty bad. If it happens more distally, like the descending, they just treat that medically. These people will go to surgery. What's that?
This is ascending, moves over, here's descending.
Yeah.
Is that going all the way to the descending there?
Yeah, sometimes it will go all the way down to like the legs almost. And sometimes they can like dissect into the arteries of the neck too. Yeah. Yeah. Okay. CT of the chest. Any guess what's going on here? Over here? Over there? Is that fluid? Yeah, this is kind of the same as what's outside the patient, right? It's just as black as the air outside the patient. So that's just air. There's nothing else in there. It's just air. So I had one of these before already. That's a large pneumothorax. So that lung is just dropped and collapsed all the way down to about that size. So they're going to chest tube also. I'll just describe this one. So we have an axial, kind of this view through the abdomen, and then a front view kind of going this way. Lots of dilated loops of small bowel. You can trace, see this one here. And it's pretty dilated. You'll just have to take my word for it on that. And then right about here, it's going to change abruptly. It goes from dilated to basically totally collapsed, right? And you can see the same thing over here. It's going to be a small bowel obstruction. It could be twisted. There could be like an adhesion or scar tissue causing that, but that person will probably go to surgery to have that fixed. Another critical finding of a belly CT. This is an axial CT through the abdomen and a sagittal view. The star is kind of nice. It shows you where the problem is. So it's very black, right? So it's very not dense, right? So that's just air, kind of like outside the patient. It's okay to have some air in your abdomen as long as it's inside of bowel like this. This is just free air floating around the abdomen. That's really bad. Usually that's caused by bowel perforation, and that's life-threatening. That person will probably go to surgery. Another belly CT. So here's a normal abdominal aorta. This is the biggest artery that runs from your chest right here, from your heart all the way down. Normal size there. Over here, it's big. This is much bigger than 3 centimeters. That's an aneurysm. This is right there. And this is the contrast that was injected, filling the lumen, and next to it, that's basically just like clot at the periphery where the blood flow is kind of slow and clotted. And here's an even more abnormal one. So the white is contrast that was injected. Anybody have a guess as to what it might have happened? It's really hard. I'll just tell you. So this is the contrast in the lumen where it should be in the aorta. And then here is dissecting probably into the wall. And then this is outside of the aorta. This is just in the abdominal cavity, right? So the injected contrast went into the artery, and it should stay in the artery, right? But it didn't. It's leaking out. So basically this aorta ruptured, and this person is actively bleeding, and the contrast is flowing into their abdomen over here. So that person has to go to surgery also. Okay, 2 coronal or frontal views of the abdomen. No contrast. Does anybody see any asymmetry at all? Anyone? Okay, so here we have kidneys. Clearly this one looks different than that one, right? This is the collecting system, so your kidney makes urine, and it gets collected in the collecting system, and it travels down the ureter, down here. If you follow it down, there's something there. It's a kidney stone that used to be in the kidney, now it's in the ureter, and it's blocking that ureter. So the ureter is super dilated, and it's going to be very painful. And if it's that big, they're probably going to have to do something about that. And this is a different patient, same phenomenon, just up higher in the ureter. To find it? Or like lithotripsy, they break it up? I don't know if they can do that in the ureter or not. I think that's what they would use. I'm really not certain. I think they would probably put a stent in. I'm not sure how they get that out, to be honest with you. Okay, that's a cervical spine CT, lateral view. Any idea what's going on here? So the vertebrae should be little boxes, right? They should stack up on each other pretty well. Be pretty flush. That looks good, that looks good, that looks good. That's not so good, right? So the back upper part of that vertebrae is broken, and the fragment was kicked back into the spinal canal where the spinal cord lives. So that's no good. So we use CT almost not exclusively, but it's the first choice for evaluating traumas. Okay, women's imaging. I won't spend a lot of time on this. It's mainly mammography, ultrasound, MRI. Typically, you'll get 2 views per side. It's kind of the older technology. Nowadays, there's something called tomosynthesis, which I'll show you in a second. That makes it a lot better. As you can imagine, with just this one view here, if there's lots of tissue there, it can overlap and can kind of fake you out. So if you have like something, normal breast tissue here, and then some here, and it lines up like that, and you take one picture of it, it's going to look bigger. It could look like a mass. That's one kind of pitfall with mammography. So every report will include in there the density, right? So it can be not dense at all, entirely fatty, or it can be extremely dense. So as you can imagine, if there were a mass sitting here, sometimes masses can look different. They can be little calcifications, but if it's a mass sitting here, it's going to be white. It's going to be as clear as day, right? It's going to be easy to pick up. Now go over to here, and if it's a small mass, it's going to be much harder to find, right? So tomosynthesis makes that a lot easier. I'm not sure how well this will project, but it's kind of similar to a CT, how I can scroll through the images and pick up a mass easier. Doesn't show up very well on that screen.
Basically go through layers of the tissue.
Yeah.
So it's kind of like your CT.
It's very similar, yeah. Okay, so here's a screening mammogram. So this is the way that it works. A woman will get a screening mammogram, and if it's negative, she just comes back in a year. But if they find something, she'll come back and she'll get additional views. So on this one, it's clearly something right here, right? Much wider, more obvious than anything else. So she came back and they did a spot compression view. The hope was they could squish it, and if it was like a overlapping breast tissue, it would kind of push out and would go away and it wouldn't be real. But they pushed on it and it was real, so What happens in that case, they go for an ultrasound, and if it looks suspicious on ultrasound, then they'll get a biopsy. Okay, next is MRI. How these images are made is pretty complicated. Found a 1-minute quick video, and that's about all I'll spend on it. Is there audio? Or, oh, okay. Okay.
Analyzes protons, which are abundant in the human body. All protons spin, creating a small magnetic charge. When a strong magnetic field is introduced, as is the case in an MRI machine, protons align with that field. The MRI technician then introduces a radio frequency pulse that disrupts the proton and forces it either into a 90-degree or 180-degree realignment with the static magnetic field. Since the radio frequency pulse pushed the proton against its nature, once this pulse is turned off, protons realign with that magnetic field, releasing electromagnetic energy along the way. The MRI is able to detect this energy and is able to differentiate various tissues based on how quickly they release energy after the pulse is turned off.
So it's really complicated. So basically, different tissues will respond to the magnetic field differently, and the machine can detect that. So I won't spend much time on that at all. There are some advantages to MRI. It's better soft tissue contrast. There's no radiation to the patient. Brain imaging is a lot better. You can pick up soft tissue lesions a lot better, and it's much better for looking at muscles and joints. So CT had windows. MRI has different sequences. The MRI tech can scan the patient differently, create different images. I'm not going to spend much time on that. There's 4 here. There's several. If you were to read these, you have to do a little bit of memorizing. You have to know like what fluid is going to look like on the different sequences. Here's a brain MRI. You can see areas of increased signal here, the little white spots. On CT, that would be maybe barely visible, but on MRI, it's clear as day. That's a person with MS. There's another brain MRI, 2 different sequences. Another advantage of MRI is that it can show an acute stroke much sooner, like almost immediately, whereas a CT scan, it might be invisible in the first 3 hours. So this is just showing a pretty big acute stroke of the brain there. I'll put this in here just to show you how good the detail is with an MRI. This is a lumbar spine. You can see the spinal cord super clear, little nerves coming off, normal discs. And here's an abnormal one. You can see a disc herniation, kind of pushing back into the spinal canal, squishing the nerves back here. Another example of how good the detail is with MRI. So you have foramina, little openings in the spinal canal that nerves exit through. And you can see them really clear. You can see this one is like wide open right there. And as you get more arthritis or disc herniations, that opening can narrow. So you can see it going from wide open, progressively narrowing, all the way down to it's basically totally obliterated here. This is a sagittal view of a knee. So this was a CT scan. Well, this is the meniscus here, these black triangles. It's like a cushion for your knee. On a CT scan, that would just be a gray kind of blob. But because this MRI has such good soft tissue contrast, you're able to see a little tear in the meniscus, which would be invisible on a CT scan. Let's see. So this is a coronal view, frontal view of a knee. It shows fluid really, really well. So all of this white in the tibia down here, all of this is edema, fluid. So on an X-ray, that'd be invisible. On a CT, that's going to be invisible. And you have a little black line right here, which might be invisible, maybe. You might be able to faintly see it on an X-ray, but it shows up really well on an MRI. It's just a non-displaced fracture. Okay, this is 2 sagittal views of a foot. So asterisk is showing you like a little ulcer, a skin wound on the bottom of the foot. A little deep to that, you have infection of the soft tissues, and then you can see a lot of white in this bone here, the cuboid bone. So that's infection of the bone. It's called osteomyelitis. So if this was a CT scan or an X-ray, that would be invisible unless it was so bad that it was eroding the bone. But MRI is nice. You can see it much sooner. Okay, ultrasound. I have a quick little video for this one also.
heart of most ultrasound systems is a device called a transducer, which uses an array of piezoelectric crystals. Piezoelectric crystal vibrates when an electric signal is applied, producing high-frequency sound pressure waves, which we call ultrasound. More importantly, this type of crystal can also work in reverse. It can produce electrical signals when it detects high-frequency sound pressure waves. When a transducer directs ultrasound waves into the body, they pass right through the skin and into the internal anatomy. As the waves encounter tissues with different characteristics and densities, they produce echoes that reflect back to the piezoelectric crystal. This happens more than 1,000 times a second. Returning echoes are converted to electric signals, which a computer converts into points of brightness on the image, corresponding to the anatomic position and the strength of the reflected echoes. A medical transducer contains a large array of crystals, which allow it to make a series of image lines that, together, form a complete image frame, called a sonogram. In addition, all the crystals are repeatedly activated many times in such a way that a complete image frame is formed around 20 times per second, so that real-time motion is displayed in the ultrasound image.
Okay, so if something is pretty dense and it reflects back more ultrasound waves, it's going to be wider. So I'll show you an example of something that I might see. This is right upper quadrant ultrasound. I'll read several of these every day. So we're looking at this part of the body here. So these images are actually made by a sonographer, somebody who goes to school just to scan patients. So we're looking right here. It's the liver and the gallbladder. So we have liver here, gallbladder here. That's a stone cold normal gallbladder. It's black. There's nothing in there. It's just fluid. Little thin wall right there. And then here is an abnormal gallbladder. It does have fluid in there, but also has something more dense, which is going to be sludge. And then there's something very bright here, so it's pretty dense, like it's a stone, or gallstone. It's going to block sound waves, so that's shown by this shadow going back here. And on the previous exam, the picture, the wall was very thin. Here it's, I think it says 6 or 7 millimeters. That's almost double the normal size. So that's somebody with a gallbladder infection or cholecystitis. Just another random exam. It's probably one of my most hated exams, a thyroid exam. So here's the thyroid here, and we do this mainly to look for nodules. Here's an example of a nodule right here. We have to measure them and talk about how they look, and then give it a grade and recommend biopsy or follow-up or no follow-up. Okay, testicular ultrasound is another thing we look at. I didn't mention before, but ultrasound can show you blood flow. So here's a normal one on the left. It's kind of homogeneous, looks about the same everywhere. Little red dots are showing blood flow. The right one is bigger, it's more heterogeneous, and there's no flow. So this would be a torsion, and this can happen to an ovary also. Here are some images of a carotid artery, and we're looking for any areas of narrowing. This is another very common exam that we look at. So you see the black area is normal, open carotid artery, and we have kind of a hypoechoic, a density right here. It's plaque, partially calcified, partially soft. This is bad because it can narrow the artery. Pieces can break off and go downstream, and downstream is your brain, so that's bad. And ultrasound can also tell you about velocities of flow, and we can gauge like how narrow something is. So I don't know if anybody's ever put their thumb over the end of a water hose and kind of sprayed it. Same kind of thing will happen in an artery. So that if it's really narrowed, the velocity is going to increase. Obviously, we do baby ultrasounds a fair amount. Whenever we do these, we have a big long checklist of anatomic structures we have to make sure are normal: heart, brain, kidneys, umbilical cord. We measure various things like femoral length, head circumference, and that'll tell us about how old the baby is and when it's going to be due. Okay, nuke med. This is a whole different part of radiology. This involves injecting something radioactive, radiopharmaceutical, into the patient, or they can ingest it or they can inhale it. And they're placed in front of a special camera that will detect that radiation and will collect that data and will create different types of images. So this will evaluate not just anatomy, but also like function. So I'll show you some examples of nuke med exams. This is a gastric emptying exam. So this patient would have had some kind of a meal, like oatmeal or something with something radioactive mixed in it. and they took a picture initially, and this white thing here is the stomach. So the technologist would have traced a little circle around that stomach there, and every few minutes they're going to take another picture, and they're looking to see like how long it takes half of that radio tracer to get out of the stomach. Like, is the stomach emptying in an appropriate amount of time? Is it taking too long? Is it like dumping too fast? That's one exam we look at. This is a ventilation perfusion scan, a pulmonary scan. So looking mainly for blood clots. They do it for other reasons too. So this has two parts to it. One, the patient will inhale a gas with a radio tracer attached to it, and it should spread diffusely, uniformly throughout the lungs. And then after that's kind of exhaled and gone, they'll inject a radio tracer into the bloodstream, and that will go to the lungs also. And it should be the same, should be a uniform uptake. But if you have a blood clot, like we saw in the CT previously, you're going to block blood flow to part of the lung, right, if it's big enough. So for PE, an embolus, you're looking for a defect, like a white area, some place where the tracer could not go because the artery is blocked, right? So that wouldn't affect the ventilation. So you'll have normal lung of the ventilation. So you're looking for a mismatch. Okay, this one is positive. The arrow helps a lot. So down here we have perfusion images. So you can see a kind of a defect right there, a white area. And if you look at the corresponding ventilation image, it's normal. So air is getting to that part of the lung, but blood flow is not. So the more of these you see and the bigger they are, the more suspicious you are that there's going to be a blood clot. Another one we do is a bone scan. We do this for various reasons. Say you see a lesion on a CT scan on a bone, and you don't know if it's malignant, if it's a met, or if it's something benign. You can do a bone scan. On the left, this is a normal patient. There's some little abnormalities, like in the knees. That's just arthritis. It's normal stuff. But on the other side, clearly that's abnormal. There's little dots everywhere. What is this? Oh, so it's a radio tracer. They inject into the IV something radioactive. So anywhere with this like bone turnover, a lot of bone turnover for some reason, it's going to take up.
That's what makes it darker. There's a lot of bone being sculpted over and over.
Yeah. Yeah.
Is that usually indicative of cancer?
Yeah. I mean, that's what this one is. These are all mets, kind of diffuse bone mets. Yeah. You can use it for other things as well. I don't read these. This is a triple phase bone scan. You can use it to evaluate hardware like prostheses to see if it's infected or if it's loosened and that kind of thing. I don't read these anymore. Another scan is a tagged red blood cell scan. So they tag a red blood cell with red blood cells with something that's radioactive and inject it back into the patient. So anywhere there's blood, you're going to see uptake. It's going to be bright, right? So you have the heart, aorta, iliac arteries. Also, the whole point of this is you're looking for a GI bleed. So you expect to see blood in certain places, right? In the heart and the arteries. You shouldn't just see blood just pop up in the abdomen. So we're looking for uptake in the abdomen, and over time, it should increase and move around like it's in bowel, right? So this is normal. And here's one where if you look over here where the arrow is, over time, you'll see more uptake starting to show up. And it's starting to kind of spread. So you compare here all the way down to there, it's clearly spreading. So it's bowel's bleeding right here, and the bowel's like passing through the bowel's bleeding here, and the bleeding is like spreading down the bowel this way. It's a positive exam. Okay. These are pretty cool. We do a lot of these. This is a PET CT. So you can combine a PET scan and a CT scan. So we have a PET scan in the middle. So this patient is injected with something radioactive. It's usually attached to glucose, a type of sugar. So anything that's metabolically active is going to take up that radio tracer, and it's going to be black on this image. So you'd expect a lot of uptake in the brain, heart muscle, and it gets excreted through the kidney, so that's fine. But uptake around it's called the hyla. It's like where the lung meets the inner chest. That is abnormal. These are probably abnormal lymph nodes. And then the person also gets a CT scan, and they can fuse these together, and you can look for abnormalities that way. They're typically done to evaluate for cancer. Okay, lastly, I have IR, interventional radiology. these are the people that do a variety of like high-end procedures. General radiologists would do like some smaller stuff, but they do the exams that need like another year of training. So I'll run through some of these. Angiography. This is when you image arteries. So they can access different arteries. Oftentimes they go through the femoral artery. So they'll put a needle into the artery and then a wire through the needle. The needle's going to come out. They'll dilate the tract, the hole in the artery with a dilator, and then the sheath goes in and stays in. And through this, they can run a long wire to wherever they want to go, whatever artery they're looking at. And then once that wire is in place, they can pick a catheter. There's tons of them. There's a few they can pick from. They can slide that catheter over the wire over to whatever artery they want to evaluate. So this is a digitally subtracted angiography image. So the computer deletes everything except for contrast. So all the bones and organs, it subtracts all of that out. So when they inject contrast, all they see is the arteries. This is kind of lower abdomen. It's the aorta here splitting in half going towards the legs. And there's their catheter going up that way. Just a couple examples of angiography images. This is the brain, and this is selective catheterization of a renal artery. So they inject a contrast, and you can see a kidney here. So why would they want to do this? What's the point? Here's an example. People get aneurysms. There's a cerebral aneurysm, so it's a weakening in the artery, causing part of it to kind of balloon out. And as you probably know, that can leak or it can rupture. So something IR can do, they can run a catheter up to that aneurysm and fill it with metallic coils, and that causing it to clot off so it won't rupture. They could put a stent across the opening of the aneurysm, preventing blood from going into it, or they can do both. Yep. Yeah. 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 So here's 3 aneurysms. That's an ACOM aneurysm, doesn't matter. It's in your head. So that right there, that little black dot right there is the aneurysm. It should not be there. This artery should come up and just fork in 2. But this is a big aneurysm coming off of it there. And it's kind of hard to make out what they're doing here, but that black dot is the coils that they inserted into the aneurysm. So they injected contrast here, and then they injected again, and you can see that aneurysm is now gone. So no contrast is going into the aneurysm because they filled it up with metal coils. There's a bigger one here. This whole thing right there is the aneurysm. And then after they coil it, it's gone. And a smaller one here. And again, it's gone. Okay, they can also treat trauma patients. So if you take my word for it, this is an abdominal CT, part of one. And this is a spleen. They injected contrast, and contrast should, of course, stay in the arteries or in the organs. And this is outside of the spleen. So this patient had a splenic laceration and is actively bleeding from their spleen. So they can put a catheter into the arteries supplying the spleen, and they can embolize that bleed, the area of bleeding there. They can inject coils, there's glue, there's foam, all different kinds of things that they can inject to stop that bleeding. You also treat areas of stenosis, like narrowing of arteries. So here is an artery. If you look there, you can see pretty clearly that's awfully narrow, right? It's like that big. And over here, it's like that big. So they put a special device across that. It has a stent loaded on a balloon. They inflate the balloon and dilate that segment again, and there's a stent now that keeps it open. You do biopsies. There are 2 different biopsy devices. So you can use ultrasound to do biopsies, like breast or thyroid or muscle. And here's the little biopsy needle. They're watching it in real time on ultrasound and getting it lined up with the mass. Oh, thought I had another one. I guess not. Anyways, they would have pushed it further in there and taken a sample. And here is probably a lung cancer. This is with CT. They're going to push that in a little bit more, get a piece of that one. And here's liver. It's an example of a liver biopsy. There's the area where they're taking the little sample there. This is an abdominal CT. The patient is lying prone. They're lying on their stomach. So they're going after a little lymph node here. And it's pretty tough to get to. They're having to sneak right past the kidney, right past the spine. to the lymph node, getting pretty close to the aorta over there. But it's another thing that they do. Oh, there's the biopsy picture. They put lines in. This is a portacath, so somebody who needs chemotherapy or other medication treatments frequently, so they don't have to keep putting lines in. They'll get a portacath placed, and it's kind of tunneled. It's underneath the skin. It goes in various places: subclavian vein, jugular vein, down to the chest. There's an example of one that's been placed. They'll do vertebroplasties, so if people have spine fractures, the vertebrae can collapse and can be squished down, and they can treat those so it doesn't hurt as bad, and also to prevent it from collapsing further. So these are x-rays showing a normal vertebrae. This one's kind of squished. They put a needle in, and then they inject cement to keep it from getting squished even more. What's that? Mud jacking? Mm-hmm. Oh, yeah. Mm-hmm. Yep, exactly. Yeah. Let's see here. So here's so this is before on top, sagittal axial coronal, and then you can see that vertebrae. Here's a normal one. This one's kind of squished, right? So they went in, and all the white is the cement they injected. And there's no, it's called retropulsion. You don't want the back of that vertebrae to collapse and kick into the spinal canal. That's very bad. So that prevents that. Here's another example. This one looks more acute. You can see all the fracture lines through the vertebrae. Fracture line here, there. They've already put hardware in, but you can ignore that. And here's after, all the cement filling that broken vertebrae. They do cryoablation also. It's another treatment that they can do. So if for some reason a surgeon doesn't want to operate on, say, a kidney cancer, they can put in these probes. This is obviously in the same patient. There's 4 here and 3 there, but these probes go into the mass, and they can actually freeze the cancer. That was it. Any questions? Oh, what's up? Oh, yeah.
What's happening on there?
Oh, okay. So this one, it's a median sternotomy. So like when you have a cabbage or a bypass, coronary bypass, they split your sternum, and then when they put it back together, they use wires, right? So I was scrolling through one day and I saw a happy face, so I took a picture of that. Those just wires, kind of holding the sternum back together. That's just a vertebral body. It always looks like that. Umbilical cords that are happy, and that's a rectum.
Real quick, why'd you become a radiologist?
So I liked anatomy, so it was either gonna be radiology or surgery, and I just felt like this suited me a lot better. Yeah, less standing all day. Yeah.
What's your favorite type of thing? You just went through a whole bunch of different types of imagery.
Yeah.
What's your bread and butter? I love looking at X-rays of bones or angio or what.
Bread and butter, probably just abdominal CT or chest CT. Yeah, that's what I read the most of. Most of the MRIs, the high-end stuff will go to like neuro or MSK. So like chest and abdomen, I'm really comfortable with head CTs, cervical spine CTs. It's kind of bread and butter stuff for me.
That's one question.
Oh, yeah. It's okay. Well, I was on the 5-year plan. It should have been 4. At first, I wanted to do PT, but I changed my mind and decided to go to medicine, so took an extra year. Yeah. I don't know. Like, I felt like I was going to go to school that long. I might as well just do medicine instead. Although this was a lot longer. But
5 was the undergrad.
yeah, yeah,
4 years of medical.
yeah.
Then a year of internship. Then 4 years of
Residency. Yep.
And then a year of fellowship.
Yep.
So,
Yeah.
all right. I've lost track of the math. So from
Yeah.
the time you graduated high school to the time that you're practicing radiology is
4, 8, 9. Is it 14?
14.
Is that right?
Yeah.
Oh, I work 7 to 5 most days. We're gonna cut that back. I think that'd be nice. 10 hours is a lot of time.
Yeah.
My last job was I think 9.
How many days a week?
Mainly 5. We work some weekends though. Yeah.
So your hours, but there are radiologists that like work overnight, or do they send that stuff like overseas?
This group we have our own people, so we have that in house. Well, within the group. My last group they sent it out to wasn't that overseas, so it's other people like in the United States. But yeah, if you want a night job, you can get night jobs easy. You can work from home, you can work from home. Yeah.
Thank you very much.
Yeah, thank you guys. Yeah, thank you.